metastatic calcification. So this is when calcium deposits in normal tissue. Normal tissue. Remember, as opposed to dystrophic calcification, whereby calcium deposits in necrotic, degenerated tissue. But here, calcium is depositing in a normal tissue. So the question is that why is calcium interested in deposition in this normal tissue? It's because either the patient has very high calcium and the calcium is looking for where to go to, and now they deposit it in the normal tissue, or the patient has hyperphosphatemia, because with high phosphates, that could drive calcium into normal tissue. So let's look at the pathogenesis. So elevated calcium and phosphates leads to deposition in tissue with high alkaline pH or rapid pH changes. And this calcium binds to the inorganic phosphates, leading to calcification and a tissue destruction. And once calcium binds into that normal tissue, then that normal tissue become dysfunction. So that prevents the tissue from doing its job. So let's look at a couple of examples. So common site of metastatic calcification, so it could happen in the basal membranes of the renal tubules, as we're going to see in a second, alveolar wall in the lungs, internal elastic lamina of the arteries, acid secreting tissues like gastric mucosa, kidney, cornea, and joints. So let's look at very high yield example for the exam, guys. So one is pulmonary metastatic calcification. So this is seen classically in patients with chronic kidney disease, because as we know, in patients with chronic kidney disease, they have problem, there's deficiency of vitamin D. So there's hypovitaminosis D, right? One. And then number two, the PTH cannot work on the kidney anymore, right? Remember, where does PTH work? Very good. It works at the proximal carotid tubule and at the DCT, right? And one of the functions of the PTH at the proximal carotid tubule, it activates 1-alpha hydroxylase. Very good. And that 1-alpha hydroxylase, right, is going to help with the activation or hydrolation of the vitamin D, so that we can have our 125 dihydroxy vitamin D, right? Another function of PTH on the kidney, particularly at the proximal carotid tubule, it helps to increase excretion of phosphates, right? So if the PTH is not working, then you can't get rid of your phosphates, and that will lead to hyperphosphatemia. So that's why patients who have CKD, chronic kidney disease, they have what? Hyperphosphatemia. And that hyperphosphatemia is going to drive calcium into normal tissue, thereby leading to metastatic calcification. And the next example there is nephrocalcinosis, whereby there's calcification of the renal tubular basement membrane. And if this is happening in the collecting tubules of the kidney, so that means that could prevent ADH, antidiuretic hormone, from binding or from working on those collecting tubule, and that could lead to nephrogenic diabetes insipidus, whereby the patient will not be able to reabsorb those free water back into the blood, and they're going to be losing a lot of free water as a result of that. And this is classically seen in patients who have too much of calcium. For instance, like patients who have sarcoidosis, patients who have primary hyperparathyroidism, anything that could cause hypercalcemia, that could lead to nephrocalcinosis, and this could progress to renal failure, guys.